on ocular surface tumors, and I'll be talking about the congenital tumors of the ocular surface and few other non-epithelial tumors. So these are mainly the list of the common things that we see in the ocular surface other than the epithelial tumors and OSSN, which of course remains the major chunk. And I'll try to cover some of them as a case-based scenarios. So epibulbar choriostomas are possibly the second most common ocular surface lesions that we see after the epithelial lesions and the OSSN. And based on the content of this lesion, they can be either a simple or a complex choriostoma, depending on which germ layer the contents are arising from. If it's from a single germ layer, then these are classified as simple ones where there is one type of tissue. And if it is more than one type of tissue, it is classified as the complex choriostomas. So dermolipoma is something which is pretty commonly seen, and this usually the location is in the temporal phoneal conjunctiva. Sometimes there can be syndromic association, most commonly with the golden house syndrome with associated preauricular skin tags. And most of the time they are present since birth, but generally tends to get manifested over a period of time. So it's the teenage or the young adults who will come to you, and generally the concern here is cosmetic purpose, because when the patient tends to look medially, this lesion tends to become visible. So the indication for removal here is mostly for cosmetic purpose, and sometimes there are very fine hair on the surface of the lesion, and even the conjunctival epithelium can get very much keratinized, which can cause irritation on the ocular surface, and that could be another indication where this lesion tends to be removed. What is important to realize here that whenever we are trying to remove a dermolipoma, never chase and try to excise the complete lesion, because invariably part of it, the content are mostly fat, that's why they look yellowish, and invariably part of it is going to go inside the orbit and will have extension around the lateral rectus insertion, sometimes around the sheath of the extraocular muscles. And since they're not well-defined lesion, if you try and go for a complete excision, you will end up causing scarring in that area around the sheath of the muscle, and if that happens, the patient will end up with diplopia, restriction of the ocular movements. So that is something which should be avoided. Our idea is only to excise or debulk rather the part which is visible when the patient is looking medially. So what you do, you mark out the area which is visible when the patient is trying to look medially or in the primary gaze, and that's the area we try to excise, and we don't kind of pull the lesion out from the orbit and try to debulk more of it. And since part of it could be adherent to the conjunctiva, usually part of the conjunctiva needs to be sacrificed, especially the central part, and in that case, if there is a loss of conjunctiva, we can put an amniotic membrane grafting and try to cover the defect. Otherwise, if it's a small defect in a small lesion, we can do a direct closure of the conjunctiva also. Important thing here is to differentiate it from orbital fat prolapse, especially in little older patients. Fat prolapse is pretty common, especially in obese patients who have thyroid eye disease or have laxity of the eyelids, and it tends to be mostly in the lateral fornix, sometimes can be in the other part also, and usually their subconjunctival lesion will be freely mobile, and the conjunctiva will be separate from the lesion, will be more yellowish, is not going to present since birth. We don't see any hair on the surface of these lesions, and so a good history and can help us to differentiate a dermolipoma from an orbital fat prolapse. Epibulbar dermoids again are pretty common, mostly seen in the limbus, so it could be a limbal dermoid or sometimes can involve the predominantly cornea, just like what we see in the first patient where there is mostly a corneal involvement, but more often than not it will be involving the limbus. In long-standing cases, because of exudation from the blood vessels, which are there usually in the lesion, you can see an arc of lipid deposition into the cornea. And this is something which is going to tell us that we are dealing with a chronic long-standing lesion. And why is it important? Because many a time these lesions, especially if they're inflamed, tend to be masquerading other non-benign or neoplastic sort of condition, can be sort of confused with them. So sometimes dermoid can have surface here because the contents are usually appendages, epithelium, as well as the appendages of the epithelium. So sometimes you can have hair follicles coming from the surface. It's a keratinized epithelium, and this is what sometimes causes ocular surface irritation, watering, and if that is the case, there is an indication for removal of the dermoid. So just to emphasize, we are talking about inflammation. Rarely the dermoid can get inflamed, but if you see here, there is this white arc of lipid deposition at the leading edge towards the cornea, and this is what tells us that it's a long-standing lesion and this is not something which is neoplastic, though there is a lot of inflammation, some dilated feeder vessel-like sort of, look also which is there. But these are again limbal dermoids. So really they can be inflamed also, especially in young adults. So mostly excision is usually for cosmetic purpose, if it is obscuring the visual axis coming over the cornea. So that's the time we can remove it. Sorry, I think I'll skip the video. Otherwise, sometimes if there is a very high astigmatism because of that, that could be one of the indication, but most of the studies have found that the scar which is left behind after the removal also tends to cause equal amount of corneal irregularity, and there might not be too much of difference in the astigmatism or the improvement in the vision. But if you are planning to put a contact lens and if the lesion is too high, you can debulk part of it. It's important if you are planning a debulking of the dermoid to assess the depth of the invasion. Really, dermoids can be intraocular, can extend throughout the cornea. Most of the time they will be limited before the Descemet's membrane, but rarely there can be extension beyond the Descemet's and sometimes involvement of the angle and the intraocular extension also. So in that case, a full thickness excision is required, and then we have to be prepared to cover the defect with a corneal or a scleral or a corneoscleral patch graft. So more often than not, it's a good idea to take help of your cornea colleagues if you're planning an excision of the dermoids. Do a UVM preoperatively, assess the depth of the lesion, and then only we plan an excision. And a counseling of the family before excision that the scar is going to persist after the surgery is very, very important, because most of the time they will come for a cosmetic indication. So what we do is, the video is not playing, but mostly what we do is we debulk the lesion, the superficial extent. We don't try to go deeper if the lesion is not going deeper. And that scar which is there in the cornea, the tattoo is put on that scar, and on top of it an amniotic membrane grafting can be done. And if it's a little lamellar excision of the cornea, you can put a lamellar patch graft also. So that tends to mask the scar, white scar which is visible, and generally this is cosmetically much more acceptable. These are the complex choriostomas, what we call as epibulbar complex choriostomas, because histopath shows tissues from more than one germ layer. Sometimes there can be cartilage, salivary gland, lacrimal gland tissues also, other than the skin and its appendages. And more often than not, they have syndromic association, most commonly with the linear nevus sebaceous syndrome. So this is a patient who has this linear nevus, cutaneous nevus, and we know that this syndrome can have other implication in terms of CNS involvement and other systemic implication. And in adulthood, many a time these areas of cutaneous nevus can develop really malignant changes. So this is something which needs to be recognized, and also the family needs to be counseled accordingly. Rest, the treatment of the choriostoma remains on the same line. If it's a cosmetic concern visible in the palpable aperture, then a debulking of the lesion can be done and the defect can be covered with an amniotic membrane graft if required. So this was one rare case where the choriostoma is actually involving the palpable conjunctiva. More often than not, we see choriostoma on the bulbar conjunctiva, but this one was actually involving the palpable conjunctiva. And this was a complex choriostoma, non-syndromic, and this patient, the main concern was the medial droop, and only on eversion of the eyelid, this was the lesion which was visible. So it's not that all dermoid, epidermoid or choriostomas will be there in the bulbar conjunctiva. Sometimes it can be there in the palpable conjunctiva, and unless and until we recognize, we are aware of it, we might mistake this lesion as something else and try to sort of, the treatment might not be appropriate. This picture is just to highlight that, the color of the choriostoma can sometimes give us a clue as to the content. If it is more of a dermoid, where there are more of epidermal elements, skin and its appendices, mostly they tend to be more yellowish in color because of the fat and the other content. If it is more of lacrimal gland component, which are mostly in the complex choriostomas, it's more reddish and pinkish in color. And if there is cartilage or other tissue, it tends to be more bluish looking color. So it might be just a small clue which might tell us what kind of tissues we might be dealing with, and we can actually try to corroborate with the histopathology. So nevus sebaceous syndrome is one syndromic association which we should look for if your diagnosis is an epibulbar complex choriostoma. Now, moving on to the cystic lesion of the conjunctiva, most often the cystic lesions will be acquired following trauma, following surgery, but sometimes we do see cystic lesions in childhood which tends to be congenital, like in this sort of lesion where the main complaint of the patient remains a drooping of the eyelid, and once the patient looks down, you can see this subtle fullness which shows that we are dealing with a lesion which is not in the orbit but possibly in the preseptal area, and on eversion of the eyelid we see this greenish bluish cystic lesion which is going to be transluminant positive, and this lesion is usually arising or adherent to the upper border of the tarsus. So these are supposed to be implantation cyst because of the when the fornix growth is happening during the developmental phase in utero. Sometimes the conjunctival epithelium can get folded or impinged into the fornicial tissue, and that's how later on in life this cyst tend to develop. And there are several reports of the cyst getting adherent to the superior rectus or the LPS muscle also. And mostly these are excisable lesions, but since the base is going to be adherent to the conjunctiva at the upper border of the tarsus, that's the area where they tend to rupture if we are not careful with the dissection. So it needs a little more patient dissection. And the other option is, if the complete dissection is not possible, we can simply marsupialize the cyst, means that we excise whatever is excisable, whatever remaining epithelium is there at the base of the lesion, we let it go into the fornix. So in a way, it tends to deepen the fornix, and that epithelium becomes part of the conjunctival epithelium at the fornix, which can avoid the fornicial shortening, which otherwise can happen if we tend to excise or sacrifice conjunctiva while excising this lesion. So these are again the implantation cyst, mostly seen in the fornix, but sometimes it can be seen in the other locations also. So this is the poster picture of the same patient. This was post-excision. But really, you can have bulbar conjunctival implantation cyst also. This was a young child, in fact, early teenager, in fact. He has this lesion since early childhood, since birth, as per the mother, but it has increased in size recently, and that's why they have come, because the cosmesis was a concern, and of course the ocular surface tear film disturbance. And again, these are lesions which are usually epibulbar, but since these are long-standing lesions, they tend to cause pressure effect on the sclera. Sometimes there can be the scleral lamellae can get compacted. There could be localized thinning of the sclera. So it's important again to assess the depth of this lesion by doing an UBM if we are planning a surgical excision of this lesion. Like in this lesion, you can see it's a very broad base which seems to be sitting on the sclera. The scleral lamella have got compressed and compacted in that area. There is thinning. So if you are not careful with the dissection here, we might land up perforating the globe. Same here, this was a slightly younger child. Here we can see the lesion infranasally, and there is a slight bluish tinge which tells us that the sclera probably is pretty much thinned out here, and we are seeing this bluish tinge because of the underlying show of the uveal kind of tissues. So the same is corroborated on the UVM, where we see an extreme thinning of the sclera at least at one point of the center. So here again the idea is either we can go for marsupialization, excise the lesion till here, till at the edges, and whatever is remaining at the base we can either just cryo and leave it there, or if it is possible to separate or scrape off the rest of the epithelium, we tend to do that. Vascular lesions can have varied spectrum. It can be small specks of dilated, tortuous, secular dilatation of the blood vessels. These are mostly the cavernous hemangiomas of the conjunctiva. Not very common, but sometimes we do see, and it's a good idea to do a good ocular evaluation, including the retinal evaluation, to rule out any associated retinal involvement also. Sometimes it can be subconjunctival lesion like this, where they tend to bleed, and that's sometimes the reason why the patient might come to you, recurrent episodes of bleed, though not very common in the cavernous malformation, more in the lymphatic, venolymphatic, but rarely they can bleed. So this was one cavernous hemangioma vascular malformation on histopathology, but the presenting complaint was a bleed, recurrent episodes of bleeding. That's the reason the patient had come. More commonly what we see are the venolymphatic malformation, which can be a combination of various venous or lymphatic vasculature, and generally tend to have an associated orbital component which needs to be ruled out by doing a good examination. If you find any proptosis, it's imperative that we do a good imaging, a contrast enhanced or at least a dynamic contrast imaging to rule out any associated orbital involvement, and also do a clinical evaluation including a Valsalva maneuver. If the Valsalva is positive, that tells us that there probably is more of a venous component, and there is likely to be an orbital deeper component which is going to be there with dilated or maybe big feeder vessels also. So again, the treatment here is either we can go for a sclerotherapy if it's a localized lesion, or if it is isolated, confined to the conjunctiva, surgical excision is also a treatment of choice. This was one patient who was treated with bleomycin. So it's a direct intralesional injection of bleomycin. The concentration varies depending on the size of the lesion, but usually we tend to put it as one international unit. 10 units is the maximum dose you can give, and the dilution based on the amount required you can reconstitute. So the vial comes in about 15 units, so based on that you can use either 5 units or 10 units, whatever is the, depending on the extent of the lesion. It has responded pretty well to just one injection of bleomycin. The third commonest conjunctival lymphatic malformation are the small cystic dilatation, which we call as lymphangiectasia. These are basically the lymphatics, abnormal lymphatics, which tends to have saccular dilatation at places. And mostly the patient will come with a complaint of recurrent episodes of conjunctival chemosis. So many a time this patient gets misdiagnosed as conjunctivochalasis. So if you find a patient who is coming with a recurrent episode of conjunctivochalasis or chemosis of the conjunctiva without any other reason to explain that, it's a good idea to do a good evaluation under slit lamp, look for those small cystic spaces, because we could be dealing with a conjunctival lymphangiectasia. So if that is the case, and if it is happening recurrent symptomatic, then we can go for either a cryo to this lesion, or we can go for excision of the lesions also. Rarely this lesion can get filled up with blood, especially during episodes of URI, because we know that lymphangiomas tends to get aggravated during the episodes of URI, and that's the time they can even bleed also. Reactive lymphoid hyperplasia, which could be a benign counterpart of the lymphoproliferative spectrum of disorders, seen in children and tends to be, or speculated to be, the etiology is supposed to be a chronic antigenic stimulation, probably secondary to some infections like either EBV or sometimes HIV also. And chlamydia infection is again supposed to be one of the predisposing factors for reactive lymphoid hyperplasia, but the data is not foolproof because the incidence of associated chlamydial detection of antigen is variable across the world. But based on this presumption, many a times they tend to be treated with doxycycline also. Otherwise, topical steroid for smaller lesion, asymptomatic lesion, and for a slightly bigger lesion like this, which was visible cosmetically and symptomatic also, we can go for surgical excision, do a good histopathology to confirm the diagnosis, and treat accordingly. Lymphoma is, of course, the malignant counterpart in the spectrum of the lymphoproliferative lesions, and we know the classic color of the salmon pink appearance of the conjunctiva, which is almost diagnostic even before you do a biopsy. So associated orbital component is present more often than not, and it is manifested in the form of a proptosis in a lesion who has a conjunctival pink lesion like this. And this gentleman, in fact, was sent from the cataract clinic because he had come for a cataract surgery, but they felt that the ptosis was obscuring the visual axis and he might not gain much after the cataract surgery. So that's the reason he was sent for correction of the ptosis, but when we everted or just pull the eyelid up, this was what was visible in the fornix. So on spot, looking at the lesion, we knew that it was a conjunctival lymphoma, and it was going beyond the fornix. We couldn't see the posterior extent of the lesion. We got a CT scan done, and you can see the thickening of the superior rectus LPS complex, meaning that the lesion is actually arising from the superior rectus LPS complex, and that was the reason why he was having the ptosis also. So these are mostly depending on the grade of the lymphoma. We do a biopsy, confirm the diagnosis, do a systemic workup to rule out any other systemic involvement, and if there is a systemic involvement, usually the treatment is chemotherapy. If it is an isolated orbital involvement, radiation works pretty well. This is one patient where there was an orbital component, as we can see the imaging, but it manifested as a conjunctival salmon pink lesion. This was treated with radiation because it was a unilateral lesion. Systemic workup was negative, and the response to radiation is pretty good. Rarely other spectrum of the lymphoproliferative, like the T-cell leukemias or lymphomas, acute leukemia, can also present with a conjunctival pink fleshy mass, almost similar to what we see in lymphoma. But this is in a child, so lymphoma does not happen very commonly in the children, especially the NHL, what we commonly see, the B-cell subtype. So in a child like this, acute onset presentation, this was in fact diagnosed as a conjunctival chemosis, treated for some time with conservative treatment before it was referred. On biopsy, it turned out to be a leukemia, and when we did the bone marrow, she had leukemic deposits in the bone marrow also. Otherwise, in such cases, if you're suspecting leukemia, even a peripheral smear sometimes can give you the diagnosis. So what do you think this is the diagnosis in this gentleman? He has these recurrent episodes of irritation, watering from the eye, and all we see is this small fold of conjunctiva, almost like a conjunctival callosis, but localized medially. What do you think it could be? All right. So this is his picture of the lesion. So this again looks like more like a subconjunctival lesion. It's not very pink, it's more, there is a yellowish tinge to it. And many a time these are the lesions which can mimic and subconjunctival extension of extraocular muscle cysticercosis, which is again something which is not very uncommon in our setup. But cysticercosis is not going to be a mobile lesion cyst. It's usually fixed to the episclera, little firm because it is tense cystic, but the color can be sometimes very much like that. But since this was not very firm, not mobile, seemed pretty soft, we decided to go ahead with the biopsy, and it turned out to be a conjunctival myxoma. And so myxoma again we used to think it is pretty uncommon, but it's not so. I think in the last last 6-7 years, we saw about 6-7 patients. And the lesion, the color of the lesion and the appearance is very characteristic. So once we see one, we get the histopath, probably the next lesion we can diagnose even without a histopath. Intraoperative diagnosis is possible because once we take out the lesion, it's very gelatinous, like a jelly. It's not a well-defined lesion. Sometimes they can extend to the orbit also along the extraocular muscle. And important to be aware of something known as Carney's complex, because a conjunctival myxoma rarely can be associated with cardiac myxomas also, and can have associated embolization from the myxoma, and can have other issues like atrial fibrillation and other issues also. So the last bit, this was another elderly lady, acquired ptosis, and she has this yellowish lesion in the fornix, conjunctiva, subconjunctival in fact, and there is some thickening of the eyelid also, medially. So generally these are the lesions which tends to be kind of, our clinical differential always remains a sebaceous gland carcinoma, especially in this age group. But one of the lesions which we need to be aware of is conjunctival amyloidosis. This again has this appearance, yellowish white, but the surface will be more waxy. The history is going to be chronic. There is not going to be any erosion or ulceration of the surface, but it can cause episodes of recurrent hemorrhage, because amyloidosis we know have blood vessels which are fragile, and it can have recurrent episodes of hemorrhage, especially in the same site. So again, biopsy with the congruent staining can give us a diagnosis in most of the cases, and I think that's all I have on the benign and other lesions. Thank you.